This is Stephen Lynn, and I'm really excited because I'm here talking to Asim Malhotra, who is a cardiologist from the UK. I'm currently in London, and it's really, really cold. But I'm actually, really looking forward to this because, Dr. Malhotra has actually been at the forefront of the diet and, lifestyle disease conversation for a number of years. And so, Asim, I'm really, happy, and thanks for talking to me today. Your own story kind of into this whole area is, I think, quite interesting because, you're a cardiologist by training. And so as a dentist, I really don't talk to many cardiologists. And so I'd really like to hear how you kind of got into this whole space and your work now.
Sure, Steve. No, thanks. It's nice to be able to speak to you. And I'm sorry about the cold weather in London. I know it's much warmer in Australia right now. I'd rather be in Australia right now.
You too, right?
Yeah, so for me, Steve, to be honest, my journey started, you're absolutely right. I trained as a conventional doctor, clinical cardiology, then subspecialized into interventional cardiology. But one thing I'd realized over my career, and I graduated in 2001, over a period of around 10 years or so, I'd noticed more pressure on the system within hospitals, more people coming in with multiple conditions, more obesity. And, you read about the headlines, you see what's going on, you observe what's going around you in the street, just walking around. And, I predicted many years ago that if we don't get on top of this soon, then our health system, our NHS, National Health Service, which I'm very passionate and proud of, will collapse. And my initial journey started with trying to really understand, what needed to be done to really curb and reverse the obesity epidemic. But one of the stories, sort of an epiphany moment for me, started when a patient who came into hospital in the middle of the night with a heart attack, who we treated for with emergency coronary stenting, essentially keyhole heart surgery to open his artery and save his life. He, the next morning on the ward round, when I was trying to talk to him about healthy diet, said, Doc, how do you expect me to change my lifestyle when you're serving me the same crap that brought me here in the first place? And he was being served a burger and chips. And, the hospital food environment, to start with, was not something that was healthy. Many doctors and nurses and clinical staff are overweight or obese. In fact, the figure in the UK is about 50% of all NHS employees are overweight or obese. Not far off, pretty similar statistics that we have in the UK with, average adult is about over 60% are overweight or obese, and 1 in 3 children by the time they leave primary school. So I started in my journey initially to look at, what needed to be done. I think the first thing I think that's quite obvious, I think most people can agree on, is actually processed food. If you get rid of the processed food or you reduce the consumption of it considerably, you're going to sort out a lot of the obesity problems. But then when I looked further into the science and the dietary guidelines, there was another problem, which was that the guidelines to suggest that we should be lowering our fat consumption and increase carbs, particularly refined carbohydrates, was fatally flawed and based upon very weak evidence. And when I reanalyzed and looked at the totality of the data, I found a lot of things that really shocked me, but I realized I needed to get out there. And one of them was that saturated fat certainly was not something that was strongly implicated in heart disease, and we'd ignored sugar. I'd realized that the evidence and the science on sugar was mounting, and we needed to reflect that amongst the population because, the average UK citizen is consuming at least 2 to 3 times now what the WHO recommends as the maximum limit of sugar consumption. So I turned my attention to sugar really being public enemy number 1 in the Western diet. And then things really took off from there. I think the other thing as well, Steve, that, I became more aware of in my practice, is that we seem to have shifted away from really practicing truly evidence-based medicine on what's important and what's best for patients. There's a system here, unfortunately, much more in the States, where it's financially incentivized and financially driven. Heart stents is one great example, where in the UK, we put in probably a third of the stents we put in for people with heart disease to unblock arteries who aren't having a heart attack. The evidence tells us that that's not going to prevent a heart attack. It's not going to prolong their life. Yet most patients, 88% of patients, think they're having the procedure done for that very purpose. So there's a big issue around too much medicine. There's a big problem of overprescription of statins. And I think the key thing is that doctors are misinformed. They don't understand the evidence properly. And then they unwittingly misinform the patient, and that causes harm. So really, we're having to battle now, what John Juanidis, who's a professor of medicine and statistics in Stanford, calls the medical misinformation mess. So really, my role is to do what's best for my patients, that I'm responsible to scientific integrity, but also, we need to collectively clear up this medical misinformation mess, both on what on health and procedures and medicines, but also make sure the dietary and guidelines reflect the evidence. So there's quite a lot to do. But if we do that, if we actually have science-based policies, then we will be in much better health, and we'll have happier and healthier and actually more economically productive societies as well.
Yeah, it's such an important message. And I mean, you're telling your story from 2001. We've come such a long way since then. And in particular, actually, I came to your launch of your book, The Pioppi Diet, last year. And, you talked about this problem with evidence in healthcare, and the same problems you're talking about, I see in the dental industry as well. We are treatment focused, but the other thing too is that when you really stack it up, are the things we're doing backed by evidence? And like you have the FDA in the US turn around the recommendations for flossing, and so there's all these kind of misconceptions that I think are very, very much confusing healthcare messages, and also it's built into the training. So it's a big problem, but you really came through the period, and as a cardiologist, you're really seeing, this diet heart hypothesis, and that was really critical to shaping this whole dialogue, I think, of what is a healthy diet, and what
Sure.
we thought, how we demonize fat, and as you mentioned there, we've kind of turned to sugar, and this obviously has a big connection to the mouth and teeth, and all of a sudden we're starting to see one problem, aren't we? And so, how have you seen the evidence turn out in terms of moving from how you would conventionally measure cardiovascular risk to a more diet and sugar connected? The evidence has changed, hasn't it?
It's a really good question, Steve. And I think one thing that people need to understand more and more as well, and I always teach my medical students this, I say medicine is not an exact science. It's more the practice of the art of probability. So we have to have a bit more humility rather than hubris, and accept that things evolve, things change. But also, I think one of the things I've realized as well is that the science alone is also not sufficient. Opposition from vested interests needs to be overcome. And as you know, with the whole sugar, awareness that's grown recently, that really was about 40 or 50 years too late, because John Yudkin, British nutritionist, actually, in the 60s and 70s said sugar was really the major issue, but he got basically, his voice got drowned by very powerful vested interests who tried to shut him down. And I think we need to understand and realize that even if we've got the science, we have to think, well, hold on a minute, there's a huge industry that actually benefits and profits from fatally flawed messages, and overcoming that and trying to take that on is another challenge. So I think let's also start from that sort of area to understand that, because people who are listening saying, hold on a minute, who should I believe? I'm confused now.
Yeah.
Well, I think if we start off saying, actually, things change, things evolve, and we need to reflect what the up-to-date evidence tells us. And of course, things will evolve even further, and I'm sure we'll refine even what we talk about as a healthy diet with time.
Yep.
But actually, at least our job as doctors and clinicians is to reflect what we know today, so we can help the patient in front of us today. But yes, absolutely. In terms of the dietary, what my conclusions have been, when you look at overall dietary patterns, I think the first thing to say, and I tell my patients this, is we need to change this focus from making cholesterol the enemy. I tell my patients, I tell people, I say publicly, we need to stop fearing cholesterol and make it your friend, because when we talk about cholesterol, people talk about high cholesterol, and they think, well, cholesterol high means heart disease, and therefore the focus should purely be on getting it as low as possible. But actually, that is actually just plain wrong. First and foremost, the traditional studies that show the association with heart disease and cholesterol actually only reveal a strong association when cholesterol is actually very high. We're talking about over 10 total cholesterol. The other thing that people don't realize is when you look at cardiovascular risk calculators, you're actually making a risk calculation based upon a ratio of your total cholesterol divided by the HDL, the good cholesterol.
Yep.
So just to put it in layman's terms, you can have two people that come to see you, two patients that come to see me. One has a total cholesterol of 7, and the other one has a total cholesterol of 4. But actually, the chap with a total cholesterol of 7 may be lower risk if his HDL is significantly higher. So say his HDL, the good cholesterol, is 2, 7 divided by 2 is 3.5. Okay, so that's the ratio that you use, and the higher the ratio, the greater the risk. But somebody with a total cholesterol of 4 may have a HDL of 1, and his total cholesterol to HDL ratio is 4, right?
Exactly.
So his rate, but people don't look at it that way, and they kind of just worry unnecessarily. The other thing is, when you look at if you have a league table of risk factors when it comes to heart disease, LDL, the so-called bad cholesterol for people who are under 50, is actually much further down the list. The most important one is insulin resistance. And that's essentially, a precursor to type 2 diabetes. And as you know, Steve, caused by, consumption of excess refined carbs, sugar, sedentary lifestyle, stress is probably implicated in there, poor sleep. So you combine all these things together, then essentially you've got most of what causes heart disease. Smoking, of course, is extremely important, as well. And historically, we know that smoking reduction has had the biggest impact in reduction in cardiovascular deaths. But now those figures have started to plateau. We've got increasing prevalence and incidence of heart disease starting to increase. So we've got to combat the diet aspect, now as well, and get that right. So I think that evolution is really what's something that needs to occur, something I've been advocating for. And then when you look at the evidence for what dietary changes, or what are what we have available in terms of what's likely to be the best sort of diet, and I talk about that in the Pioppi diet, it is the best components of the Mediterranean diet, and it's not all the starch and not the pasta and the bread, because I've not seen a single study that's shown that eating bread and lots of pasta reduces cardiovascular disease. It's going to come from things like lots of vegetables, olive oil, oily fish, handful of nuts. Those are probably the components that really combat the inflammatory processes that lead up to causing heart disease. So these should be the base of your diet, and you should have less starch and less sugar. I think another issue is the fact the most modern bread, Steve, certainly in the States, I'm sure you notice this as well.
Yeah, absolutely.
But modern bread is very different to the type of bread that people were consuming in the traditional Mediterranean diet when you go back 50 or 60 years ago, which was often baked in the home. And we found that in Pioppi. The glycemic index is much higher of modern breads compared to the kind of bread they were eating. And they didn't have any sugar in their diet, very little. Pioppi, in this village, southern Italian village, where their average life expectancy is close to 90, when we asked them how often was sugar consumed, they said only on Sundays. Their dessert was only on Sundays. Now think about the modern Western diet. We're consuming sugar, many people are consuming sugar 3 times a day, whether it's sugared cereal in the morning, some sort of sauce, sugar in, a mid-morning snack, dessert in the evening or whatever. So there's a lot more sugar consumption, which is really a metabolic time bomb. Now, a small amount of sugar is not going to cause a problem.
Yeah.
But on a population level, that's not. We're consuming way more than our body can deal with, and that's when you get this whole sickness problem and type 2 diabetes in kids even.
Yeah, no, and it's so apparent, especially in your book, The Pioppi Diet. You've really I think it's really ground zero of kind of where this idea really kind of started, wasn't it? Because it was where Ansel Keys, spent a lot of his time and created his diet heart hypothesis. And when you really kind of go in and dig into what what he was talking, it doesn't really stand to reason. And so you just kind of put it into a really good nutshell, is that this refined sugar is hitting our palates at least 3 times a day. And dentists have been talking about this for decades, and we've been losing the battle against sugar the whole time. But then the breads that we eat as well, it's refined flour, and it behaves very similarly to sugar. So we've got this problem where we've completely flipped. And then there's the protective factors, of the health mitigating foods that they ate. And so that's such an interesting story, and it's
absolutely
lost, isn't it?
Steve, you're absolutely right. And in fact, the traditional Italian diet as well didn't have, pasta really as a main course or lots of pasta. It was always eaten as a small starter with olive oil. And then they'd often eat vegetables and fish and that kind of thing. So, they were able to deal with it because it wasn't, there wasn't any added processed food, no sugar, no snacking. And they were able to handle that. And I think if you're not insulin resistant, I think it's estimated now that at least 1/3 of Americans are insulin resistant or have markers of prediabetes. Then this sort of dietary pattern is fine. But I think depending on where you are in the spectrum, certainly we know that people with type 2 diabetes, they benefit most in terms of blood glucose control and even sending their type 2 into remission, if you like, or some people like to call it curing their type 2, but at the very least we can say remission, normalizing their blood glucose levels without medications, happens when they really cut out the starch, all the starch and the sugar.
Yeah.
But then the diet that they follow is one that is enjoyable, it's very healthy, it doesn't have any restrictions really on fat. And I think one of the things that's been forgotten in this whole issue about fat is, one, we know it doesn't clog the arteries, and two, it's satiating. You know, it keeps you feeling full. It also has the least impact on glucose and insulin responses. So, you know, I think I think we need to focus on the quality of food that people are eating and forget about this counting calories, really, because the counting calories thing really is a, you know, this calorie focused concept allows the food industry to sell low calorie junk food.
Yep.
You know, how often do you see people saying broccoli has this many calories, or broccoli being marketed with this many calories? You know, it's whole fruit and vegetables. Does it need to be marketed on the amount of calories it has? You know, it's actually low fat junk foods, 100 calories in this pot of yogurt or this ice cream. And actually that it works very much in the favor of the food industry, because, as you know, Steve, of all the macronutrients, carbohydrates and sugar have the least amount of calories. So this is an excuse to really market cheap sugar.
Yeah, and you know, there is such a movement in terms of health packaging, and you know, where health bars and, you know, even cereals are kind of marketed as healthy because they're low calorie or low fat, and is just packed with all of these disease, driving ingredients. And so exactly what you're saying there really has pushed us so far down the wrong track. But you really hit a good point there, I think, is that, you know, we've really come across as, we know that fat doesn't clog arteries, and so that's something that we're still turning people's kind of, you know, thoughts and this dogma that eating fat clogs our arteries. And so actually, you know, there's some really interesting studies, isn't there? I really wanted to ask you about how we can measure cardiovascular health, and the coronary calcium score is really kind of, you know, moving towards being, you know, a perhaps more definitive way of measuring cardiovascular risk. Is that have you found that in practice?
Yeah, sure. I mean, I try to use it sparingly when it's needed, but certainly when you look at, you know, when a patient comes to see me, the biggest factors really in terms of their risk is metabolic syndrome. So for some people that don't understand what metabolic syndrome is, first of all, the importance of it is that about 2/3 of people admitted with heart attacks now, Steve, have the definition of metabolic syndrome. And if you have metabolic syndrome, you also got an adverse prognosis in the fact that you're 50% more likely, relatively more likely, to either die or be readmitted to the hospital within a year. So, and most people admitted with heart attacks now don't actually have cholesterol, which is outside the so-called normal range. So, metabolic syndrome is the issue. So how do we define metabolic syndrome? Metabolic syndrome is any three of the five of high blood pressure, impaired glucose tolerance or type 2 diabetes, high blood triglycerides, low HDL, low good cholesterol, and increased waist circumference. So those are the things that I look out for. And actually, they are very predictive generally about someone's risk. But the good news is you can change, you can reduce that risk from the simple lifestyle changes, which means cutting out the processed food and walking and concentrating on reducing your stress, for example, stopping smoking if you're a smoker. So those are the most important things. The calcium score is very useful because it's a non-invasive way of actually measuring coronary artery calcium, which is very strongly correlated with coronary artery atheroma, or blockages, if you like, for the layperson. And it also predicts risks of future events. But I try to not use it unless it's absolutely necessary. I think it'll have more and more use as we move forward. In particular, I've seen a number of patients who've come to me who actually have very, very high cholesterol levels. So they're diagnosed with familial hyperlipidemia, genetic abnormality, which gives them very high cholesterol. But even those people are a heterogeneous group, Steve. So, of course, a significant number of them, about 50% of women, untreated traditionally, 70% of women untreated. Sorry, let me get this right again. Sorry, I'm going the wrong way here. So with familial hyperlipidemia, around 30% of untreated women will develop premature heart disease, and about 50% of men. But the converse of that is 70% of untreated women will have a normal lifespan, and 50% of men will have a normal lifespan. So that group is heterogeneous. Now, I've had a number of patients come to see me who are in their mid-50s, very fit and well, suddenly got their first cholesterol check done, really, and found their cholesterol sky high, meaning they have familial hyperlipidemia. But they don't want to go on a statin drug because, for whatever reason, they don't want to have side effects, or they just generally don't want to take a pill. And the calcium score has proven very useful in those patients because what the logic is this: if high cholesterol for you is a risk factor for heart disease, you've had it all your life, you're going to have some heart disease at the age of 55. Okay, so the calcium score can tell you whether there's any heart disease. And many of my patients, in fact, all the ones specifically who've come to me with this question, their calcium scores have come back as normal or zero or very close to zero. And therefore, they can be reassured that for them, their high cholesterol is not cause heart disease. And therefore, they can then make an informed decision not to take a statin. So I think in those particular patients, it's very useful. But for other people as well, yes, of course, it can be very useful. But I think my approach to use of calcium score is that use it as a means for most people to institute, if they've got a calcium score that's high, but they haven't got any significant symptoms, they don't need a bypass operation, to use it as an opportunity to put them appropriate medications if pertinent, but for them to institute lifestyle change, say, listen, you can significantly reduce your risk of having further a heart attack or a premature death by changing your lifestyle. And I think that's key. The problem is most conventional doctors don't really are not empowered to give that information in necessarily the right way, and it becomes an excuse, or it can often lead to over medication as well, and that's something we have to be wary of.
Yeah, no, that's such a great point, and you're really kind of speaking to a much broader view of the body, where we're seeing metabolic syndrome, all these other risk factors that are all pinned into this lifestyle that you're talking about, is directing this risk in the end place. And so one thing I've seen in the mouth, for instance, is that obviously gum disease fits into this whole spectrum, and I really think that calcium balance and the fact that you guys are starting to measure this, and this conversation is, we're really going to see that the body's management, and so inflammation in the gums, for instance, and moderate to severe periodontal disease, which is much higher percentage in people with metabolic syndrome. We are dealing with the one factor here that we've got a problem with the body's dietary input, but also the management of calcium in the body too. So adding that to the diagnostic tool just makes so much sense, and hopefully we can connect this, because one of the moments that pushed me down the road to writing my book, The Dental Diet, was a patient that was going in for quadruple coronary bypass surgery, and so he actually was referred to me by a cardiologist who wanted a dental clearance, and you'd be familiar with that. So that was the system in Australia. This was the first time I'd seen the patient. So he had severe gum disease. I had to extract his last teeth, and
wow,
he never made it through the surgery. And so that really highlighted to me just how disconnected we are in terms of understanding these early warning signs that can be, we can pick up these early warning signs in the mouth. And if this conversation was more significant within our system, I believe we would potentially be able to reverse and prevent those those situations. So it's so great that you've done all this work into really kind of unpacking this problem, and that it really is working towards understanding this from a much more logical and an empowering way as well, because ultimately people have much more control over their health.
Absolutely, Steve. And I think another important point as well is it's never too late. I mean, people's lifestyle changes can have quite dramatic impacts in a short space of time. And when we wrote the book, The Pioppi Diet, we call it a 21-day plan.
Yep.
But, that was really to change. It wasn't selling it was basically to change the narrative. So people actually realize, because this is what I see in my own patients, people are coming back following this kind of plan, and their blood triglycerides go down, their HDL goes up, their waist circumference comes down, they feel fitter, their blood pressure gets better. Type 2 diabetes their glucose control, obviously it's going to be it's going to vary from person to person. But I think that the thing about the 21-day plan is it's also good, and I'm sure you've seen this as well with sugar. I mean, a lot of people are, in many ways addicted to sugar. Absolutely. But you need to go cold turkey. And, I found myself, having been a former sugar addict, is that when I went cold turkey, it took about 2 to 3 weeks, but then my cravings disappeared, my taste buds adjusted. And I think that's quite extraordinary as well for me, because I was always craving sugar. I thought it was normal, to always feel that, I wanted something sweet. But when I went cold turkey, 2 to 3 weeks later, I was amazed that I wasn't craving it anywhere near in the same way. And now I don't really crave sugar at all. I mean, yeah. I can't remember the last time I really craved any sugar. And this is coming from somebody that for, most of his life, I was consuming a lot of sugar in most of my life. Probably, I was very active, but probably 30 or 40 teaspoons of sugar a day. So,
oh no,
if I can do it, other people can do it too.
yeah, no, and that story is so interesting because I was talking to my periodontist friend last week, and he was saying how so many medicos and so many dentists have gum disease and have dental problems because we're eating the same diet that our patients are eating because we don't understand the problem, and it's this horrible system. And I noticed the same thing in myself where I was eating far too much sugar without even realizing it. Without
Sure.
having the low-fat yogurt with some kind of berries and dark chocolate and some honey. And I was packing myself with 100 to 150 grams of sugar a day without even thinking about it. And so, it is just a problem that if healthcare professionals can't understand it, we really have to put our hands up here, don't we? It's, what hope does the public have? So I think we're moving forward, and, obviously the book that you and Donald wrote has been very instrumental, and I really, applaud your work because obviously heart disease is one of the biggest problems that we're unpacking here. It's really it's one of the biggest ones that people fear. So I think you sending out this message is so important. So I thank you a lot for that.
No, thanks, Stephen. It's really great to have, finally get a dentist to stand up and talk about this stuff as well, because, that's it was the elephant in the room for a while in a sense, because, one of the things that I learned and really shocked me, the statistics that, in the UK, the most common cause of chronic pain in children and hospital admissions in young children is tooth decay.
Exactly.
And the single biggest culprit driving that is sugar. One of the few things, as you know, that corrodes teeth enamel. Yet, I found that statistic really shocking. And obviously the debate and the discussion was still ongoing about sugar's role in type 2 diabetes and heart disease, and all the vested interests that are trying to undermine that. But no one can argue against the teeth issue.
No one can argue. That's exactly right. Yeah. They can talk about, kind of confuse the situation with metabolic syndrome and heart disease, but there is no arguments with tooth decay. Those numbers were just the other week, by the way, went up. You probably saw the numbers too. They were reported that hospitalizations for infants with having their childhood dentition taken out grew in the UK again.
Yeah.
And that is just alarming. That's the childhood.
Yeah, and Steve, and my understanding as well is, there's been this sort of public perception in a way that we're not worried about the tooth decay sugar so much, because as long as you look after your teeth and you brush your teeth, you'll be fine. But I'm sure that's not true. You can't keep up, right, with the amount that people are consuming. I don't think you can outfloss a high sugar diet, can you?
Brushing, we know the evidence doesn't support that. Flossing really, has an effect, against disease. So it's the same problem, very similar to what you were seeing with blood cholesterols and, measuring, these certain heart markers. We've looked at the problem all wrong. We have to go back and look at those core parts of the diet. Yeah. So it's amazing how much synergy there is in the conversation. So, I've really enjoyed this, and so thank you for joining me tonight. But so your book, The Pioppi Diet, is available on Amazon?
Absolutely, yes. You can just Google it and get it on Amazon, and it's available in UK, all Commonwealth countries, and it's coming out recently. It's come out recently in a few other countries such as Denmark, Portugal, Brazil, etc. But yeah, UK and all Commonwealth countries.
Thanks, Asim. Thanks for your time, and I look forward to chatting more about diet and your next book, of course.